Okay, hello. People are here. I can see participants piling up. Fantastic. Thank you very, very much for coming along, giving up your Tuesday evening. We are going to have fun. We've got about an hour to talk through. There's some housekeeping involved, and let's get that out of the way early, and maybe we can repeat a bit of it towards the end as well. Firstly, we need to say thank you. Thank you, Sean. Thank you, Rosie. Thank you, Linda. Thank you to the Royal Society of Medicine. Thank you to Michael Rapp, generous support in ensuring that this is provided free. Thank you for putting together episode 8 of a 10-episode series on what I think we can all agree is the biggest global health threat of the 21st century. This is episode 8. The first 7 or so covered all sorts of topics, anything from the relationship between climate change, human health, and air pollution, dermatology and skin, diet, child health, mental health. It turns out when you look, you don't have to look very far. The climate is everywhere. The environment is everywhere. When it changes, it has a pretty profound effect on human health. This session is provided free of charge, like we said. There's CPD points, all important CPD points up for grabs. To get access to them, you got to make sure you complete the survey at the end of the session, give a bit of feedback. Unfortunately, only available for those who are watching on demand, not available for those that are watching over YouTube or where this is recorded. And a full list of resources sent out at the end. That's the housekeeping. Quick explanation of what we're going to do, quick explanation on who on earth I am, and then an introduction to our panel members. Every single session I go to where I see 5 or 6 experts talking about interesting things, interesting research, interesting work they're doing. I love that because you get to hear their 20-minute sort of spiel on what it is that they're talking about and interested in, but then you don't get time for discussion. We're going to flip that around. No presentations, just discussion. We have about an hour. There's a chat function and a question and answer function. Please ask all of the questions that you possibly want to ask. Please try and take a look, upvote questions that you want to see asked. It might just help me, your aberrant moderator, figure out where the interest is. But that's it. That's the entire housekeeping. My name is Nick Watts. I am the Chief Sustainability Officer for the NHS. Strange job. The NHS's first Chief Sustainability Officer, a really interesting job, really very simple. The NHS has made a commitment, net zero for the emissions we control directly by 2040, net zero for the entirety, because we are good healthcare professionals, the entirety of the NHS's emissions, scope 1, 2, and 3, including our supply chain, by 2045. We're very serious about that. My job is to help us move from commitment in October 2020 to a net zero healthcare system in 2045. So, kicking us off, I might quickly go around and introduce some people. I'm going to be very informal. You can tell I'm informal. We can all agree that all of our panelists are incredibly esteemed, are well-educated, are well-written. So maybe if you'll permit me, guys, we have first Chantelle Rizan. She's an ENT research fellow, University Hospital in Sussex. I think that's right, Chantelle?
Yes, absolutely. And I'm also a surgical research fellow at the Royal College of Surgeons of England and a sustainable surgery fellow at the Centre for Sustainable Healthcare. So coming towards the end of my final year of my PhD, in which I explore ways to reduce the environmental impact of the operating theatre. So specifically looking at that evidence basis for meeting net zero within a surgical context.
Love it. We have Jody Sherman, all the way from the United States of America, Connecticut somewhere, Jody. Jody's the director of the Yale program on healthcare environmental sustainability and an anesthetist, associate professor of anesthesiology at the Yale School of Medicine. Anything to add, Jody?
Well, I guess importantly, even though I'm an anesthesiologist, the work is, well beyond anesthesiology, perioperative services, interested in drugs, devices, clinical care pathways, healthcare systems operations, materials production, transportation, packaging, the whole kit and caboodle, as we say.
Yeah, instead you might just need to list the things that you're not an expert in. Next up, we have Jason Snape. Jason is the global head of environmental protection at our good friends AstraZeneca. Jason, anything to add there?
Yeah, I am. Thanks, Nick. And I've got an interesting or an exciting challenge, the same as you. So that's taking AstraZeneca to being net zero or carbon zero by 2025 for its own operations, but actually carbon negative across its entire value chain by 2030. So that's our contribution towards the climate crisis at the moment. And we can explore that a little bit further over the next hour. Absolutely.
Finally, we have Rosemary Coenda. Rosemary is the coordinator of the United Nations Informal Interagency Task Team. Rosemary, if I summarize, you're responsible for making sure that across the United Nations, we get sort of sustainable procurement right for the health sector. Is that right?
For the health sector, that's correct. So the informal task team on sustainable procurement feeds into the formal structures of the UN HLCM. That's correct.
There you go. Okay. So we have quite a few people listening in live. There will doubtless be many millions more, obviously, listening to this recording. For the people here live, you have your experts in front of you. We have clinicians, we have people expert in supply chains, we have aberrant Australians. I might, though, if it's okay, take the first question, and it's a question I'm going to ask to each member of the panel, and whoever's bravest can put their hand up first. The title of the session, Building a Greener Health System, I'm going to say is nonsense. That's not what this is about. That's not enough. We need to build a net zero health system, right? We need to go about as far down this path as you can possibly go. Green, 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 net zero. Jason, you're right. Eventually negative. Is it possible? That sounds ludicrous. Do you really think that the NHS could get to net zero by 2040, 2045? Do you really think AstraZeneca could get there by 2030? And why do we think that it might even be, not ridiculous to talk about? Who wants to take that on?
I'll pick it up, Nick. So yeah, I absolutely think it's possible. And I think it's the journey that we've got to take. We're facing a climate crisis at the moment, but I think what we also have to do is focus on what we can deliver. So look at our own operations, our scope 1, our scope 2 emissions, tackle those in the short term, work with our downstream value chain wherever possible. But then actually to reimagine healthcare more holistically. So actually to look at healthcare systems and just see our role, our suppliers' role in that broader healthcare landscape. And it's to start to try and reimagine care in a low carbon world. So to challenge how we're existing practices are for delivering care, the level of travel, the clinical interventions that go in, and say, well, how can disease prevention, how can early diagnosis, earlier clinical intervention improve patient outcomes, but also reduce the environmental footprint of that broader care pathway, recognizing actually certain components of that care pathway, their footprint might increase, but actually the net effect could be lower across the whole of that footprint.
So the net matters, absolutely. Who else wants to challenge me? Is this possible? Net zero healthcare system?
So we'd add at this point, I think we're right at the very start of this journey, and there's of course a lot of low-hanging fruit. We've got a growing body of evidence, both from the published research and from other sources, and we do have a reasonable idea of some of those actions that we do need to take at this point. And so a lot of the effort, I suppose, at this initial stage of our journey is about implementation and some of those challenges in terms of engaging the whole of the surgical and the wider healthcare community, and all of those involved in the whole ecosystem, upstream from industry and those involved in the reprocessing and downstream and waste and so on. So I think we do have a reasonable idea of that starting point, but it's then a question of identifying the areas that we actually need further investment and innovation in order to actually meet those gaps. But I think ultimately, as we've just heard, focusing on disease prevention and health promotion, and optimizing the care that we provide our patients, that is at the heart of providing sustainable healthcare systems.
And Chantelle, while you're speaking, let me draw out the first question from our audience. Very simple. There is too much plastic in my trust, too much plastic waste, especially with PPE. Is there a policy being introduced to deal with the recycling from the NHS? I can answer part of that. but this is your area of expertise. I thought you might want to speak around it.
Yeah, absolutely. So I actually recently published a paper within the Journal of the Royal Society of Medicine, topical as we're talking on the RSM right now. But within that, I quantified essentially the carbon footprint of the 3 billion items of PPE that we used during the first 6 months of the COVID-19 pandemic. And within that, essentially estimated that that equated to over 100,000 tons of carbon dioxide equivalents. And that, just to put it in context, equates to around an additional 1% burden on the NHS. So that, of course, is moving us in the wrong direction. When we're trying to meet net zero, it was actually an additional approximately 1%. But interestingly, I wasn't just interested in quantifying the scale of the problem and saying how bad this was. It was also a question of looking at the strategies for mitigation, and through modelling a number of strategies, including adoption of domestic manufacture, as well as reduction strategies, particularly focusing on rationalising our glove use, as well as switching to reusable options where they were currently in existence, as well as using optimal recycling. It was theoretically possible actually to bring that right down to around 75% of the burden. And so we need to be essentially looking at these various methods and identifying ways that we can provide essentially safe protection to our staff and also to our patients, whilst actually mitigating and really minimizing that impact that it has on the environment.
Can I ask almost a question that's been on my mind around some of this, Chantelle? So the question asked specifically says, is there something being done, at an NHS-wide policy level? To which the answer is yes, right? There are efforts to do some of what you're talking about, move production closer to home. There are efforts to look at innovations in the kinds of PPE that we might be able to procure as a system. People will have seen, because Twitter saw all sorts on a large bit of procurement around single-use PPE, which is now followed up with some pretty significant amendments there that I think should reassure us. My question: how much of this has to be done and is done best at a single national level, and how much of this can be done by an individual clinician, down in a hospital?
So I think in each and every interaction with patients, then it is essentially a clinical decision in terms of actually the level of PPE that is required, and it is then having a sensible consideration of the risk of that individual patient, as well as the extent of the contact you're going to then have. So I think there's a huge opportunity to actually make reductions from a clinical level in terms of our glove and also apron use. And if we look at the actual contribution from gloves, it was actually around 45% of the PPE that we were using. And so I think on a day-to-day level, then certainly we do have autonomy over the PPE, the volumes that we're using. Then in terms of the availability of some of those reusable alternatives, that I suppose is more about some things at a local and a national level, which we do then require leadership upon. And also in terms of the recycling strategies, again, that involves the relevant infrastructure being in place, which a day-to-day clinician may not be able to implement so much.
Yeah, that makes good sense to me. Jodie, this butts into your area of expertise as well. So maybe you might want to comment, but you might also want to take up the challenge. A net zero healthcare system, is it possible? What about in the United States?
Wow. I don't want to be a joy kill. I mean, I think we absolutely must aspire to net zero emissions. It's really predicated on changing a very complex system, including, particularly in the US, our insurance system, right? Because we are incentivized for, even our nonprofit hospitals are incentivized by doing more procedures. And so we really have to change our payment incentive structure. We also have to change our regulatory processes, and this is, I think, a global issue, and that includes on what devices and drugs are approved for reuse. There should be a lot of processes in place that include making sure that their emissions are reported, not just greenhouse gas emissions, and also minimized. And that needs to be transparent. And particularly around the regulatory procedures, I think a lot has to do with our infection prevention procedures and policies. because they really are a major driver of wasteful practices in drugs and devices. We have to throw a lot of things out that are potentially at risk for cross-contamination. There is the presumption that single-use disposable is better from infection control. For things that are difficult to clean, small IV catheters and tubing, that's certainly the case. The vast majority of things, there is no evidence to suggest that the vast majority of our things need be single-use disposable. It's more a matter of convenience, just like our to-go coffee mugs is convenient. So too of our medical devices. And then our perceptions around infection control. So for example, as Chantelle was talking about gloves, and you were asking about individual, what we can do on the individual level. Well, it's well known that we don't wash our hands enough. We don't need to glove up every single time we touch a patient. We need to wash our hands before and after we touch our patients. And obviously, if there's sterile procedures, we need sterile gloves. And if there's risk of bodily fluids or open wounds, then of course we have to wear some gloves, and often not sterile. So pretty complex. And so I addressed a lot of your questions there. And I look forward to the next one.
Let me ask, just drawing on something from the audience, Jody. It's a pointed question. It's a good question. It's an open secret that medical practice is defensive. Protect the clinician first and the patient's benefit only after that. We can agree or disagree with that, but how about we focus on the second part of the question here? How will you build a sustainable health system if over-investigation, over-prescribing, and over-medicalization is not addressed? Perhaps if you focus on that second part.
Well, we certainly can't build a sustainable health system if we continue to come through the, certainly medical legal concerns are part of that. I think, defensive medicine is not unique to the United States. But in order to address overuse and underuse, which is another problem, we really have to come through the lens that I think is that a moral issue, that we must consider safety for patients as well as public health simultaneously. And every single behavior that we do, every single thing that we use and prescribe, we need to be knowledgeable of the latest evidence, and we need to importantly apply a risk reduction approach. So zero harm, zero emissions, these are the highest aspirations, but we have to be realistic and really determine, will a drug or a treatment reduce the risk of or lessen the harm from a particular condition. So we can't make everything go away, but the idea is we need to try and reduce these. And so it's really about risk stratification.
Makes good sense to me. It's that area around overprescribing, over medicalization. I think there are some really important synergies with the direction that medicine is just heading anyway. There's a new director focused on some of that coming into the NHS in a month or two. Number 2 on their job description is to align that agenda with the net zero agenda. They just fit together so clearly with the basics of what you learn in, seminars like this. Rosemary, I've known about the work that the UNDP and you've been doing on sustainable procurement for years and years and years. It is talked about as though it's sort of world leading, I suspect, because it is. Is it possible, right? Do you look at the end of this and say net zero procurement across the world, eventually we could get there?
Well, Nick, I think I'll start by saying that it depends on all of us to make it happen. And I think it can happen. Depends on the level of climate ambition we all have. And I like to re-echo what our administrator, Kim Steiner, always says when he talks about climate ambition, that we are currently in 135 countries. So if these 135 countries working on their climate ambition and demonstrating through their nationally determined contributions, are we able to scrutinize that we're not leaving anyone behind? So the work we do, or the work that I focus on, is generally around the health systems and their ability to generate these environmental impacts, both at the upstream and downstream, like Chantelle said earlier on. And we know that these range from, the way we deliver services in the health sector, and in turn contributing to this huge climate change and chemical contamination, resource depletion, biodiversity loss, air and water pollution, but to what extent are all of our health care providers cognizant of this fact? And we know that governments, at least now, on every continent, hopefully, are developing, or they are in the process of developing policies. They are also in the process of developing regulations, legislation, and strategies to foster sustainable public procurement as a means to tackling climate change, to tackling chemical pollution and biodiversity loss and more. But you see, Nick, the issue is that we need to recognize that Scope 3 is a huge contributor to climate change. And I was happy that my colleague Jason talked about Scope 1 and Scope 2. But in our work at UNDP on sustainable procurement, we're focusing on the Scope 3 emissions. So what we have done, again, learning from you in the NHS, actually you are leading the way, NHS UK, Scotland, along with Sweden and the US, I must say, Jody, you are helping to lead the way. And so we take those good practices in sustainable procurement in the health sector to make sure that the health sector can be the lead. And we're happy also to have used international conventions to make that happen. For example, in the elimination and run up to elimination of mercury in the health sector, working with WHO and with Healthcare Without Harm, with their huge network of hospitals, go around the more than 400,000 hospitals that have subscribed to Global Green and Healthy Hospitals principles, and also the Global Compact principles. So yes, it is possible, but we need commitment. We need to scrutinize the nationally determined contributions. We need to retool health workers to participate and jump on the bandwagon to net zero emissions by 2040, like you said. Let's have that ambition, but we need to leave no one behind. Unfortunately, countries are still left behind, and we've seen what COVID has done. It has exposed the level of countries that are left behind in terms of sustainability in the health sector. Over.
Can I, Rosemary, on that ask, in your job, because you have a unique perspective different to the rest of us, right? You aren't just seeing what's happening in England or in the United States. You're seeing this across the entire world, high, middle, low income country. Where's the demand for this work coming from? And I mean that both in terms of which countries, but I also mean that in terms of where within that country. Ministries of health, individual clinicians, where's the...
So the demand, Nick, is coming from ministries of health and ministries of environment. The dilemma we have is that generally ministries work in silos, and so do most of our institutions. We work in silos.
Yeah.
And so the breaking down of these silos has to permeate from global levels, regional levels, country level. And at country level, we need to look at cities, we need to look at municipalities, we need to look at health ministries, we need to look at hospitals and small health facilities. So taking issues from bottom up. So the demand is everywhere. It's with hospital services. Like I can cite examples of our project that we're implementing with Healthcare Without Harm in 10 countries. And we've tried as much as possible to have a widespread. So we're focusing on lower and middle income countries where UNDP and Healthcare Without Harm are developing and piloting a set of sustainable health procurement practices and policies. Sure. So we've chosen countries that include India, China, and Brazil among the the world's leading manufacturers of health commodities. We've also gone to Argentina, Moldova, South Africa, Ukraine, Tanzania, Vietnam, and Zambia. So we have been drawing on, the Global Green and Healthy Hospitals Network, and we collaborate with these countries, also in the scale-up countries, including Colombia, Chile, Argentina, and also in the Philippines and Republic of Korea, in Vietnam, in Indonesia. So we've seen that the demand to bring experiences and technical expertise from, say, private sector and also the health facilities in countries such as UK and Sweden, the United States. We try and bring all these synergies in the project to make sure that UN-wide systems are tackling sustainability in the health sector and use different entry points. And to the extent possible, we have tried to limit our objectives to basically 4 of them. The first one, to develop a globally adaptable criteria and standard for sustainable manufacturing, distribution, and content of products, of those products that the health sector procures. So with this index, we are hoping that the uptake of changing systems and criteria adherence by procurers and manufacturers of health commodities will improve. Secondly, is capacity. I think you agree with me that there's a lack of capacity, especially from our procurers. And it's good that we have Jason from manufacturers' point of view, but we're also looking at some manufacturers who also require capacity for sustainable production, supply and disposal of health commodities. And then thirdly, we need to understand the application of the appropriate indicators and the evaluation of what we do in promoting sustainability using sustainable procurement measures. So the demand is from low-income countries, middle-income countries, and also sharing among high-income countries.
Rosemary, that warms my heart. I should have asked which countries are not interested. There was a world 10, 15, 20 years ago, right, where you could put the number of people that cared about this work in a small phone box. No longer the case, right? Jason, I hope you don't mind if I come on to you. 1 or 2 questions have shown up. I'm sure you've seen them. AstraZeneca is interesting, not quite unique, but pretty damn close to it. AstraZeneca, GSK, Biogen, those are the only 3 I know of that are major pharmaceutical companies that have net zero scope 1, 2, and 3 commitments and are, I think, walking the talk, aligned with what the NHS is looking for. But the questions maybe are challenging that. This is ambitious. Surely it can't be true. Prove to us that there's some credibility here. Surely there's an argument of needing to look into the wider healthcare system so that we can avoid thinking about the actual things that AstraZeneca is responsible for. Come back at us.
Yeah, okay. So in terms of our climate ambitions, they're not new. So we've had science-based targets since 2016, and we've invested 100 million over the last 5 years and actually reduced our scope 1 and scope 2 greenhouse gas footprint by 60% already. We've got a clear path to our 2025 target to be carbon zero for scopes 1 and scopes 2. So our residual challenges or opportunities are around clean, affordable heat, transitioning our road fleet and 17,000 vehicles over to electric vehicles. And then we've got F-gas emissions associated with the production of some of the respiratory products that we make, and then just a few little bits of the tail. So we're well on our way to actually delivering. We've got a plan in place to actually execute those remaining steps across all our assets and our sites. And we're already at 99% renewable purchased power. So actually, we've only got 250,000 tons of CO2 to remove still from our scope 1 and scope 2 footprint. And I'm confident that we're going to get there 90 to 95% through avoidance, through reduction, and through substitution. There may be a small residual amount in 2025 that we might have to compensate for. And we're even designing that in to some of the clean, affordable heat options, so the biomethane options that we're looking at with some of the suppliers that we're looking to execute at the moment. And we've delivered this 60% reduction in our greenhouse gas footprint over the last 5-6 years, whilst we've actually been growing as a business. So we're improving our energy productivity, so you can decouple natural resource consumption from the growth of your business. In terms of that longer term 2030 target, you have to recognize we're an innovation-based pharmaceutical company. So many of the products that we're bringing to market in 2030 are still in R&D, or they're still in pharmaceutical technology and development. So we can design in carbon neutrality, we can design in sustainability, we can pick our suppliers and our logistics for the generation and manufacture of those products. But we can also work with our suppliers to help them embrace that journey towards science-based targets. If they take those net zero ambitions and align them to the Paris Agreement 1.5 degree C target, that means they're going to reduce their footprint by about 46% over the next decade. We can also partner with them around supplier power purchase agreements. We have to recognize, so we can help them on their journey to net zero. But we also have things like kind of our respiratory portfolio. So we're investing in next generation propellants with a near zero global warming potential. And we'll be transitioning from 2025 to 2030. So people can still have PMDIs, but actually with a net zero or near to zero footprint. And we're investing $1 billion to do it. And the one benefit I've got is the leadership that we're getting from the top. So whilst I have accountability for delivery, I report directly on a 6-weekly basis to the CEO and the CFO, who's actually tracking this and making that conscious decision around the investment decisions that we're making. So we have that ownership by our senior leaders within the team. And I think the other way in which we're looking at things is not just in terms of buildings and assets, we're also focusing on our products. Because that's where we're going to get scrutiny in the marketplace with that transition to a low carbon economy. So we're generating those life cycle assessments of the goods and the services and of our products. So we know what are the most carbon intensive areas in the manufacture of that drug, or the logistics or the patient use of that drug, which are the suppliers that actually have that most carbon intensive footprint, so we can design it out. And yes, by 2030, we are going to have a residual footprint that we're going to have to use nature-based solutions or engineering solutions to get to net zero. But what the NHS is going to have confidence in, and the other health or care authorities by 2030, is that any product that you're buying from AstraZeneca is going to be net zero. So that's helping you on your commitment, and we will not be looking at the broader healthcare pathway as a systems approach to help us on our journey. We will be helping you on your journey to net zero through the procurement of our products.
Much appreciated, yes. The NHS's Scope 3, let's say it very clearly, Scope 3 commitment is not possible unless we either decarbonize alongside our partners like AstraZeneca, or we just stop purchasing anything from anyone. And one of those is clearly not an option. Let me just ask, almost out of my own interest. So you said 250,000 tons left in your Scope 1 and 2, 250 kilotons left, which is really not that much, actually. CO2e, I presume. By context, the NHS's Scope 1 and 2 emissions, 6.5 megatons. Our Scope 1, 2, 3, 22 megatons. I'm interested in how low that is, but I'm also interested in what you do or don't do in terms of your calculations for an inhaler that you might sell to the NHS. So we buy inhalers from AZ, and we're very interested, in fact, critical, that they drastically and rapidly reduce carbon. We count that. Do you count the carbon in what you sell us as well?
Yes, we do. So in terms of our Scope 3 footprint, so one of the categories there is actually looking at the downstream use of our products, and the respiratory use accounts for about 12% of our Scope 3 footprint currently. And obviously that's one of the elements that we're tackling with the next generation propellants. But obviously there are other opportunities that the NHS can look at in tackling the over-reliance on SABA at the moment. And if you tackle that and move towards maintenance devices for asthma, then there's opportunities to reduce your footprint probably by about 250,000 tons of CO2 equivalents per annum.
Yeah, it's the number of patients that are prescribed over 6 SABA inhalers per month in the NHS is a little alarming. You look at it, you go, that surely must be an error.
And there are other opportunities as well with chronic kidney disease. So if you've got a patient on dialysis, then potentially their environmental footprint is 4 tons per annum higher than somebody that's not on dialysis. So actually disease prevention strategies, so non-clinical interventions, or even early diagnosis and clinical intervention can actually reduce the footprint of some of those care pathways. So I know we work quite closely with the Sustainable Healthcare Coalition to try and map out some of those care pathways, try and challenge the think where we can actually help support kind of decarbonising that route through actually reducing the reliance on actually having to go into hospitals, so some of those transport related costs, having actually innovations at the moment in personalised medicines as well. So we know that actually the patients taking our medicines through the companion diagnostics are more likely to respond to that treatment. So actually that's generating less waste actually for the whole of the healthcare system.
That makes sense to me. I'm going to ask one more question of my own, just because, sorry, I'm learning as we go, Jason. And then Chantelle, there's a couple of questions in the chat for you. 2025, Jason, those PMDIs you're talking about, that sounds great. It also sounds a little too slow for the NHS. We need to move a little quicker. You'll know that we're trying to reduce the emissions from our inhalers, not in 5 years, but in 5 weeks. In fact, we want to see a 90% reduction over the next 3 years for our total inhalers. Are there things we can do to move faster together on that?
I think the challenge we've got is one of regulatory pressures. So obviously we've got to go through some of the clinical studies for these next generation propellants, and that comes with significant investment. So I know we're investing somewhere in the region of about 300 to 400 million on these trials at the moment, and that comes with timing, but actually it's maintaining that patient choice, that patient selection, because I think at the moment the concern I have, and I don't just run our carbon program, I run our water, waste, pharmaceuticals and the environment, products environmental stewardship, is that if you look at carbon, things like dry powder inhalers, yes, they look good on paper, but actually if you look at their wider environmental footprint in terms of plastics, their water use, their eutrophication, their environmental toxicity, they actually score much worse. So I think if you make a short-term transition just purely on carbon, there may be some unintended consequences that you have to rectify a little bit later on. So for me, it's stay patient-centric, probably tackle some of the SABA-related issues at the moment, and actually track what innovation's going on within industry, because I think you may be able to have that choice between MDIs and DPIs from a carbon perspective in 4 or 5 years' time.
That makes perfect sense to me. 4 or 5 years is too slow, but I understand the barriers. That's fair enough. Chantelle, can Chantelle please give us a few bullet points on how carbon footprint can be decreased in surgery in a theatre? Chantelle, maybe you could give us 3 or 4, and then Jody, maybe you could give us the next 4 or 5.
Absolutely. So I think further to everything that has been discussed today, then absolutely the very first priority in terms of actually meeting or moving in the direction of net zero within surgery will be that focus on surgical disease prevention and on actually optimizing our patients as part of perioperative optimization. We need to be looking at those things that can actually reduce complication rates, which in and of themselves in handling those complications, they've got a high carbon burden. And some of those things might involve things like use of active transport and reducing red and processed meat consumption. And so these things will have co-benefits in terms of actually in and of themselves reducing environmental emissions, but also improving that individual's health itself. And so then when we think about, okay, so a patient has actually got to the point of actually requiring surgery, it's then about looking at how do we streamline those processes and looking at those opportunities to actually optimize the patient pathway. Within the actual operating theatre itself, we've got opportunities looking particularly at our single-use pre-prepared sets and looking at those items that are perhaps never used. It's absolutely criminal that these things are essentially thrown away without ever having been used. And at that point, we can then think about using reusable options where they're available. And specifically with reusables, we can then look at optimizing that further, in particular focusing on decontamination processes and optimizing those, as well as looking at opportunities for repair. Most hospitals do actually have repair processes in place, but they're often underutilized. And so actually in the operating theatre, when things appear to be damaged or blunt and so on, actually asking for them to be sent for repair as opposed to discarding them straight away. And my own research has indicated that that actually has the chance to reduce the carbon footprint of those reusables by around 20%, with cost savings also. So we then get down to sort of the worst case scenarios, and if we're in the position where we really do need to be using single-use items, it's then looking at opportunities for reprocessing, or otherwise known as remanufacturing, where we look at actually sending these things so that they can then be reprocessed for a further 1 or 2 uses. And the absolute worst case and our last resort is then looking at recycling. But as you'll be well aware, Nick, our waste is responsible for less than 5% of the carbon footprint of the NHS. And so recycling is not enough, and actually focusing on those things far upstream, starting with disease prevention. And of course, if we don't need the operation in the first place, then that's going to be the much greater impact than actually making those decisions between, do I use this reusable or single use item? So I suppose that would be my overall framework in terms of my main pointers as to how we can actually think about our actions within the surgical setting.
Jodie, improve on that answer.
Hard to improve. I would expand, of course. So, just building on this idea of whether or not a surgery is necessary to begin with is such an important topic. Whether or not a patient wants surgery, even if it's not necessary, is something that has to be seriously addressed, just as we do with antibiotic use. Professional guidelines about when a procedure is indicated also need to be addressed, that they need to be adhered to, as well as reassess, for example, whether or not to do prostate biopsies during the last 10 years of life is something that we know for a fact patients get far more than they need to. So the guidelines are adhered to, and furthermore, the guidelines can be revised. Do patients require surveillance biopsies every 6 months, for example? Building on what Chantelle was saying, and I think people appreciate that the kits that we use are overstuffed. They're designed to appeal to the most users as opposed to being streamlined. It's such a difficult thing for us to streamline a kit in the United States for consumable materials. It actually costs more money because it's considered a custom kit, which is, it's such a scam. There could be a few different kits that are more streamlined. And then what surgeons pick for materials for their operations. Of course, we require, I imagine it's the same in the UK, we require that these pick lists be reviewed on a regular basis, either every 6 months or 12 months. But beyond that, so firstly, it's not actively enforced in the United States. I'm not sure about the UK, but additionally, they could be reviewed before every case, because the way a case is booked, the way it reads on paper or electronically is not necessarily what the surgeon knows that patient requires. So they could actually be reviewed on a case-by-case basis. On the anesthesia side, we certainly know that inhaled anesthetics are very potent greenhouse gases. They're just blown off the rooftops. So strategies include, there are waste anesthetic gas capturing and destruction technologies. I think that their benefits have not been independently reviewed. I think that they are valuable, but importantly is to actually avoid inhaled anesthetics to minimize our fresh gas hole use, or the quantity that we use, and particularly avoid desrain and nitrous oxide, which are the worst offenders, and a whole particular unique issue in labor and delivery that we can address, but also addressing infrastructure. So a lot of the nitrous oxide is actually lost through old piping systems. And also on the infrastructure side, our HVAC systems, so heating, ventilation, air conditioning, and cooling systems. They typically run 24/7. They have very high air turnover rates that is not evidence-based to try and minimize infection risk. So those policies around what the turnover rates need to be assessed, and there can also be off time setbacks. So when rooms are not in use, they can be turned down. And then particularly since we have our colleague from AstraZeneca here, I want to address one big issue on the medication side that has to do with our drug vials being much bigger than we actually need for a particular patient, and all sorts of policies that prevent us with good intention to prevent cross-contamination, prevent us from splitting them between patients. There are multi-dose or single-use vials, but even multi-dose vials in the United States, we are not allowed to split between patients if they're opened in patient care areas, which is most of what we do. There is the opportunity to make those vials right size or do pre-filled syringes that are appropriately sized, and also the expiration dates, both on our medical devices and also our pharmaceuticals need to be justified. And I'll leave it there.
And can I ask Jody on that very last point? Is that a regulatory problem? Is it a supply chain, provider problem? And the reason I ask is we had an issue somewhat similar, and we grabbed together a couple of experts from the company that produced the drug we were talking about, and we grabbed together a couple of people from MHRA, the regulatory agency in the United Kingdom, and said, listen, this is really simple. We should just be able to solve this. Can't we, the three of us in this room, or 9 of us, or whatever it was? And they all said, the regulator said, we don't have a regulation that prevents you from doing that. And the company said, we don't have a problem with that whatsoever. And the clinicians said, we don't have a problem either. And it turned out that we had all been looking at each other saying there must be a regulatory problem. That's the issue. But when we actually all sat down and talked, there was no problem. I just wanted to tease out what the barrier is.
Sure. Are you talking about splitting vials?
No, I'm talking about a completely different thing altogether. I was just pointing out that I had actually been walking around saying there's a regulatory issue, followed by MHRA saying, no, there's not. Go for it. Good luck to you. No,
you mean regulatory issue preventing splitting of vials?
No, Jody, I'm not talking about vials whatsoever. I'm talking about a completely different issue. I'm interested in what the barrier is there. Is it a regulatory problem that you're talking about, or is it a supply chain problem?
I think it's a bit of both.
Sure.
So the supply chain problem is that businesses are incentivized for selling more things, as opposed to incentivized for durability, for things being, for their, or justification for expiration dates, for example. And on the regulatory side, it's, getting back to the medical legal thing. Or, even beyond that, it's this, there was a very interesting paper, I can't recall if it was a Lancet or BMJ that recently came out, but very eloquently describes that this the problem of, and it'd be interesting to see if this applies to net zero healthcare, but the problem of aspiring to zero harm when it's unattainable is that it creates all sorts of siloed policies and behaviors that result in unintended consequences in all sorts of ways, and that it really should be about risk reduction.
That makes sense. There's a question here that is not for anyone on this panel, it's for me, I think. Do you mind if I answer that? Fine. Who's being held accountable for being able to track these targets within trusts, CCGs, let me add integrated care systems, ICSs? What are the consequences if they don't meet it? I'm in a trust that doesn't yet have an SDMP, Sustainable Development Management Plan, published. What the hell, man? I think is the context of the question. I agree. What the hell, man? Let me say, who is accountable? Who has to hold them accountable? I do. I do, but not alone. Me, Chantelle has to do that. People that work in the trust, Hannah Chase, the person that asked the question, has to hold them accountable. The chief executive has to be held accountable for that, which is to say we can't wait for a bearded Australian somewhere in London to make sure that every single trust, all 230 of them in the country, have a net zero strategy. We all need to be shouting about it. And if they don't, we just need to shout louder and louder. For our part, though, we've been pretty clear. And you can expect a couple of letters, fairly strongly worded, out to every chief executive in the next couple of days saying very, very clearly, we expect every single trust, no exceptions, to have a net zero strategy, a green plan. Every single integrated care system, no exceptions, to have a net zero strategy and a green plan. It doesn't have to be perfect, but it has to have a couple of things you're going to do very, very early on in 2021, 22, and we can fix it up together. That's going to be tough. This is going to be the first time that we are going to start mandating that. We are going to start following up every single trust, every single integrated care system. So we better provide some capacity. So we're setting up net zero teams in every single region across the country to help provide some of that support. Net zero procurement team, net zero medicines, net zero ambulance transport, everywhere you look, okay? And not 6 figures of capacity, not 7, 8, 9, not 8 rather, but nine figures worth of funding investment capacity per year heading into the system for 21, 22. You'll hear more about this in a couple of days at the NHS England Public Board on Thursday to make sure that this is viable, to make sure that we can start to take those first steps. Is it enough? Absolutely not. Absolutely not. It's not enough. We're always going to have to do more. That's the great thing about climate change. You can bust a gut, put an effort in, and you could always do a little bit more and go a little bit further. That's my very simple answer. That question was getting a couple of likes and I didn't want to duck it. We've got 8 or 9 minutes left, guys. There was a question in here, and I might encourage people, if you want, you can see the questions, you could type some answers if people on the panel wanted to do that. But there was a question in here that I'm just going to go back and try and find that I thought that is a very nice question that we should wrap the session up on. I've lost it. Let me try and paraphrase. This is tough. This is hard. This work is ambitious and often thankless. Everyone here in their own right, I think, is doing some pretty impressive things. Rosemary with the United Nations Development Program, Chantelle, Jody with your respective healthcare systems, Jason, AstraZeneca is a world leader in this space, right? There's a reason why AZ has been, and Pascal has been invited onto the international leadership group that the NHS is pulling together here. What keeps you motivated? What gives you energy? Why do you do the things that you guys all do? Simple question to help us end on. Who wants to go first?
Well, what keeps me motivated, first of all, as a health professional myself and working for the United Nations Development Program, I think healthcare professionals really have an important role to play in fostering, wide-scale behavior change and leading the transition to more sustainable healthcare systems globally. Whether we like it or not, healthcare providers are really trusted leaders within society. So I think we have a unique opportunity to advance sustainable healthcare and influence public policy for better protection of the health system and communities around us. And also, we need to collaborate more. When you ask me to come and speak and be part of this, that's part of the motivation, to collaborate and hear about best practices. Now you're just telling us how ambitious you are in the NHS. We take these stories to others, make sure that we continuously advocate for healthy future by reducing the environmental impact of healthcare. So the race to net zero, in my view, is not simply a climate change mitigation strategy. It is a societal transformation towards healthcare and well-being for everyone. So that keeps me motivated. Thank you.
And from my regard, I'm an environmental scientist that's worked at AstraZeneca for 26 and a half years, so more than half my life, but I actually go into work every day still as refreshed as the first day that I go in. And for me, we haven't got a second chance. It is a climate crisis. We have to act now. We've got to collaborate. We've got to partner wherever we possibly can. But I think if we reimagine healthcare in a low carbon world and we work collectively across our various functions to do that, I think there are significant benefits that we can realise, and they're benefits for the environment, they're benefits for society and patients. But actually, I think they're going to be benefits for the economy as well. So I think it's a win-win-win, but we can only do that if we harness our collective power.
So I think, as we're all aware, the Lancet Commission originally posed climate change as the greatest threat to human health of the 21st century, but it was actually subsequently then reframed as the greatest opportunity to actually improve health, because actually the actions that we take today will have a significant impact in terms of the health outcomes of the future. And I do feel that we do have a responsibility to our future patients as well as healthcare professionals to actually design and build these sustainable healthcare systems. And ultimately, this comes down to improving sustainable value. So we're, as clinicians, very used to thinking about our individual patients in front of us, and perhaps the wider population outcomes, but it's then balancing that against the triple bottom line and ensuring that when we are acting to actually improve the health of our patients and population, it's then not at the expense of either the financial sustainability or environmental or social sustainability. And so if we really take that focus in terms of actually optimizing clinical effectiveness, but then balancing it against those three different domains, I think that's where we have our greatest opportunity. And I think this is such an exciting space to be working in. We're right at the infancy, and there's so many areas that we can take action in our day-to-day choices, which ultimately will have a large impact if we all collectively as a community apply these green lenses to the various different spaces that we're working in.
Yeah, so I would echo all that's been said thus far, and I would add from my perspective that there are really two motivations here. Firstly, I think is optimism, right? I think we all believe that a better future is possible. Those of us here doing the work, that we do know that there are solutions. We do know that we can do better. And the other is a duty that we know we must do better. We certainly have the duty to our individual patients, but we also have duty to protect the Earth's natural systems upon which intergenerational health and well-being depend. And so those two things combined, I think, is what moves us forward, moves me forward.
Love it. Excellent answers, well timed. We're 2 minutes away from close. My answer to that question, what keeps me motivated, is you guys. This job is hard. This work is hard. It's thankless. But we have some of the world's smartest, brightest, most energetic people, organizations, companies working on the problem. It's that I think gives me a bit of energy that, we'll get there eventually. That's it, everyone. We've answered some of the questions. We haven't answered all. I'm very, very sorry. One day we will do this again and we can answer them in more detail. Before we wrap up, I need to thank once more Sean, Linda, Rosie. Thank you guys so much for setting this up. Thank you again to Michael Rapp, his generous support, ensuring that this is provided free of charge. And a final reminder, that survey for CPD, that's what gets you the access to those points. Unfortunately, only available to those here watching on demand. Thank you very, very much to everyone who's given up their Tuesday. Look forward to seeing you again soon.